My beloveds, today's topic, gastritis. Something like comprehensive overview for medical students, and not only for medical students, why not for my young colleagues. Take your pens, papers, and let's go on. If you receive, for example, on your big board exams question like this, gastritis. So what is gastritis? Gastritis refers, from the name we understand, it refers to inflammation of gastric mucosa, my beloveds, which can range from mild irritation to severe erosion. It might be acute or chronic, presenting with a wide array of symptoms and underlying causes. So gastritis can be classified based on its etiology, which broadly includes infection causes. So, okay, if you have this question, for example, infection causes of gastritis, you start with Helicobacter pylori tail. So you said, yes, Helicobacter pylori infection is the most common cause of chronic gastritis. Of course, it's a fairy tale. It's never happened, nothing with real medicine. It has nothing with real medicine. But on the exam, don't say, it's nothing with real medicine. You said, yes, Helicobacter pylori infection, the most common cause of chronic gastritis. Then, viral infections. Yes, such as cytomegalovirus and herpes simplex virus. Maybe you can feel this when you have got cold, my beloveds. Common cold, just common cold, not obligatory influenza. You feel something not okay in your stomach. It's highly likely it's a cytomegalovirus or herpes simplex virus or viruses like that. Then, rare but happened, fungal and parasitic infections. Of course, they can occur in immunocompromised patients because normally our stomach is with H. chlor. That's why immunocompromised patients can have this problem. Then about chemical and toxin induced cases. So the principal cause, my beloveds, of all gastritis, duodenitis, so-called peptic ulcer, etc., of course, it's non-steroidal anti-inflammatory drugs. NSAIDs. So the theory why NSAIDs provokes, it's a prostaglandin theory. We know that NSAIDs, non-steroidal anti-inflammatory drugs, inhibit prostaglandin synthesis, causing mucosal damage. Bad quality alcohol, not all alcohol, bad quality alcohol, and very interesting, not strong alcohols, like I don't know, vodka, whiskey, no, wine, for example, etc. Causes direct irritation and inflammation of gastric mucosa. But you don't say about quality or not quality. You say just on exam, just alcohol. But the principle, of course, it's chemical, non-steroidal anti-inflammatory drugs. Now the principle. That's why if you receive a patient like this, you ask about non-steroidal anti-inflammatory drugs. Then bile reflux due to impaired pyloric function, bile reflux, and some corrosive substances such as acids, alkalis. Then we have autoimmune causes. I repeat, it's a broadly classification, of course. Autoimmune atrophic gastritis. Remember that these types of gastritis often associated with pernicious anemia. Results from antibodies attacking parietal cells and intrinsic factor. Then stress-related gastritis, actually, maybe also two principal causes of all gastritis and duodenitis and peptic ulcer, etc. are stress and NSAIDs. Often seen in critical ill patients, stress-related gastritis, but not always. Just stress, you might remark, for example, before exam or day of exam, you feel something like gastritis. It's a real stress-related gastritis. And other causes, radiation gastritis, iatrogenic, due to radiotherapy for abdominal or thoracic malignancies. We know that this radiotherapy can provoke a lot of problems. Pericarditis, pleuritis, as well as gastritis, so-called radiation gastritis. Granulomatous conditions, including Crohn's disease and sarcoidosis. Don't forget about smoking. I'm sorry. Smoking, of course, may provoke this problem. So about pathophysiology, primary pathophysiological mechanisms involves disruption of the gastric mucosal barrier, leading to inflammation and subsequent tissue injury. Factors affecting the mucosal barrier include, increased gastric acid secretion, decreased bicarbonate production, so our body produces this bicarbonate production, soda, impaired mucosal blood flow, direct mucosal damage, of course, NSAIDs, alcohol, autoimmune destruction of parietal cells. Then we've got a morphological classification. We have acute gastritis, morphologically characterized by neutrophilic infiltration. Then we've got a chronic gastritis, characterized by lymphocytic and plasma cell infiltration. Atrophic gastritis involves the loss of granular structures and replacement by interstitial type epithelium or fibrosis. Connective tissue, replacement normal body by connective tissue, normal cells by connective tissue, fibrosis. Erosive and hemorrhagic gastritis associated with superficial erosions and bleeding. What about symptoms, clinical presentations? Symptoms can vary based on the severity and type of gastritis and may include, of course, abdominal, so-called epigastric pain, burning or gnawing in the nature, nausea and vomiting, sometimes accompanied by hematemesis in severe cases, loss of appetite, it depends, of course, especially in chronic cases, bloating and bleaching due to gastric irritation and enzyme deficiency, indigestion and dyspepsia, common in both acute and chronic forms due to enzyme deficiency, melena or hematemesis indicative of erosive or hemorrhagic gastritis. What about diagnosis? Of course, we start with history and physical examination. Assess for risk factors such as smoking and NSAIDs use, consumption. My beloveds, ask this question several times. Ask this question, my beloveds. So, do you take NSAIDs? No, I don't take anything. But actually, after several times asking, yes, yesterday my wife gave me something against my headache. Highly likely it was NSAIDs. Even one NSAID can provoke serious problem. Conduct a thorough physical examination focusing on epigastric region. What about laboratory investigations? Of course, complete blood count, CBC. Why? To assess for anemia. Serological tests or stool antigen test for tails, Helicobacter. So serological test is for Helicobacter pylori antibodies. Stool antigen test for Helicobacter pylori detection. But of course, gold standard for detecting the problem is endoscopy. That's gold standard. Essential for visualizing mucosal changes and obtaining, why not, some biopsies. Can reveal erythema, erosions, or atrophy. And if it's not me on your board exams, you can talk about fairy tales about histopathological examination confirms the types of inflammation and presence of Helicobacter pylori. And urea breath test, very fashion now, at urea breath test, non-invasive method to detect active Helicobacter pylori infection. Now about complications, my beloveds, peptic ulcer disease due to chronic mucosal damage, we will talk by the grace of God, gastric atrophy associated with autoimmune gastritis, and finally, not good sign at all. Gastric carcinoma, for example, particularly in cases of chronic atrophic gastritis, gastric polyps can arise due to chronic inflammation, actually controversial point. Pernicious anemia, what is pernicious anemia? Due to vitamin B12 deficiency. No, if it's not, he is not a vegetarian, your patient. So management, treatment measures, general measures, lifestyle modifications, avoid NSAIDs, even NSAIDs is a provoker, avoid quit smoking, and avoid alcohol, no alcohol actually. Dietary adjustments, frequent small meals, avoidance of irritant foods, and eating at the same time, regime. Pharmacological management, no famous proton pump inhibitors, PPIs, omeprazole and brothers, reduce gastric acid secretion, H2 receptor antagonist, ramotidine, famotidine and brothers, decreased acid production. Antacids provide symptoms relief, and if it's antibiotic therapy for Helicobacter pylori, something actually extraordinary, awful. Combination therapy, clarithromycin, amoxicillin, and a proton pump inhibitor. Remember, my beloveds, we do know now that some strains of Helicobacter pylori appear to have a protective effect against certain conditions, such as GERD, gastroesophageal reflux disease, and obesity-related metabolic disorders. Remember that. So, treatment for specific types. If we have autoimmune gastritis, we remember that this is pernicious anemia. That's why vitamin B12 supplementation, stress-related gastritis, prophylactic use of acid-suppressing drugs in critically ill patients, no calming procedures, prevention, so NSAID use caution, healthy lifestyle, that is balanced diet, regime, moderation in alcohol consumption, quit smoking, routine surveillance for patients at risk of gastric carcinoma, and Helicobacter pylori eradication, reduce recurrence associated complications. Prognosis of gastritis varies depending on the cause of the effectiveness of your management. Most patients recover with appropriate therapy. With chronic atrophic gastritis may increase the risk of gastric cancer. God forbid. In conclusion, I can say that gastritis is a multifactorial condition with a wide spectrum of presentations and complications. Early diagnosis and appropriate management are absolutely essential to reduce morbidity. Thanks for your attention, my beloveds. Don't forget to follow and subscribe my Dr. Y YouTube channel and as well as my Dr. Y Telegram channel. Dr. Y, like me it's Y. WHY. Dr. Y, it's me. So you type in searching mode in Telegram, Dr. Y, WHY, without question mark, of course. Dr. Y. You find this, you click start, and you choose your plan. Stay blessed.